Hi, my name is Bijal Shah from the Moffitt Cancer Center in Tampa, Florida. And thank you for inviting me to share a summary of my presentation at this year's SOHO 2023 annual meeting. I discussed the approach to sequencing immunotherapy in B-cell ALL. We know that immunotherapy has transformed what we do. We know that now with the ECOG 1910 data set, that blinatumomab can be safely incorporated into frontline therapy for adults with ALL, and that it improves overall survival in patients who are MRD negative with, before receiving blinatumomab. And I think that's a really important starting point for this conversation. It means that we can anticipate that blinatumomab in particular will be a component of multi-agent therapy for most adults with B-ALL because of the survival improvement that was observed therein. We've also seen very compelling data with inotuzumab incorporated into frontline immunochemotherapy, and this is what we've seen from the MD Anderson group in particular with the mini-CVD inotuzumab protocol. Here we're seeing, even in very older patients, that this can be safely incorporated and that it appears to come with a clinical benefit. Relative to our historical standards, we're now, really extending survival in our older patients with this addition. And it's not just MD Anderson, we're seeing it across other studies in the US and Europe as well. So where does that leave us with CAR T-cell immunotherapy? So in the relapse and refractory setting, we can see that CAR T-cell therapy really extends overall survival with a 3-year OS that is now estimated around 45%. But for most patients, they will be receiving CAR T-cell therapy based on these really compelling frontline studies after either inotuzumab or blinatumomab or possibly both. And so what was really important for us to try to understand is how these prior exposures inform our expectations with CAR T-cell immunotherapy. What we saw with blinatumomab is that it did come with a numerical decrease in the response rate. And, it did not meet statistical significance. It was also associated with a numerical decrease in the expansion of CAR T cells, again, not statistically significant. Interestingly, we also looked at patients who received blinatumomab as their last line of therapy. In other words, they were blinatumomab refractory coming into CAR T cell immunotherapy. And again, numerically a decrease in the expansion when we saw this, but without meeting statistical significance. Where does that leave us? Well, I think that there's probably a subset of patients who truly are resistant to CD19-directed immunotherapy, whether that's a reflection of CD19 antigen downregulation or loss. And we've seen papers that describe this in the context of mutations in CD81 or PAX5, or whether there are other mechanisms. I think these are all things that are actively being investigated. For the remaining patients, though, I don't think that failure of blinatumomab is something that we should be worried about as we make the decision to proceed with CAR T-cell immunotherapy. And that's reassuring. Now, we certainly didn't stop there. We also looked at duration of response. We looked at overall survival. And the key take-home message is for those patients that responded to CAR T even after failing blinatumomab as their last line, the duration of response was preserved. We did not see any significant impact at all in duration of response for those individuals. When we talk about overall survival, the 3-year overall survival was, again, numerically less, but it was not significantly impacted by the prior blinatumomab. This is in line with what we're seeing with real-world data with tisagen occlusal in pediatric patients, and so reassuring that we're also seeing it here in the context of B-ALL. One of the questions that came up then is how do we distinguish tisagen from brexacaptogene. And one of the things that I thought was reassuring came out of Crystal Mackel's group, which was the idea that CD28 based CARs like brexacaptogene may be actually more responsive in the setting of low CD19 antigen burden. Again, clinically, we're seeing responses with both Tisagen and Brexu in this context. So I want to make it clear this is preclinical data that I'm referencing here, but certainly reassuring if we're concerned about lower CD19 antigen density in the context of brexacaptogene. It seems as though these CD28 based CARs like Brexu can still work quite well at killing cancer cells in that context. So I'm going to pivot here and talk a little about inotuzumab. When we looked at our inotuzumab, patients who had received prior inotuzumab, we again saw preserved responses. Again, a very slight decrease, I think from 72% to 67%, something around those numbers. And you can cut the numbers out of the final recording if you'd like, but it was a very modest, if any, change when we talked about the response rates in the patients who had prior inotuzumab versus those who hadn't. And so we also saw the same thing when it came to expansion. There was really no discernible difference in expansion in patients who had received prior inotuzumab and those who had not. I think where things got really interesting, however, is we did see a significant decrease in 3-year overall survival expectations with among patients who received inotuzumab before CAR T-cell immunotherapy. And I don't know how to make sense of this. I suspect it's small numbers. Honestly, there was a total of 17 patients across the phase 1 and phase 2 who had received prior inotuzumab before coming to CAR T-cell immunotherapy. And I say this largely based on data, again, out of Europe, looking at inotuzumab both as bridging and as prior therapy, pre-CAR, where they had shown, again, in the pediatric space with Tisagen Laclusil, no significant impact on duration of response or overall survival. So my best guess is, this is one of those, one of these findings that may be better explained by what inotuzumab failure looks like, right? So where does inotuzumab not work, and what does that patient look like when they're coming into CAR T-cell immunotherapy? And these are going to be very high tumor burden patients with extramedullary disease. These are going to be really tough leukemics, and my best guess is that's what drove a more inferior outcome, given the fact that they had preserved responses, preserved expansion, everything we really need to be seeing with CAR T-cell immunotherapy. The other possibility is because inotuzumab can be myelosuppressive, and we may be seeing that magnified perhaps a little more in our adult patients relative to our pediatric counterparts, where they may tolerate the myelosuppression, the infections that come, along for the ride. In our adult patients, they may be less tolerant, and so the inotuzumab then followed by CAR T-cell immunotherapy, that sort of back-to-back approach, maybe coming with more myelosuppression as a consequence. We may be seeing the impact in terms of survival as a reflection of that. So, it's not really the INO per se, but just the challenge of really taking sick patients to CAR T-cell immunotherapy. And that was really one of the big take-home messages of my presentation, which is, yes, it's okay to give these agents before CAR T-cell therapy, but we want to be careful. We want to be cognizant of the fact that as we treat patients, with one line after the next, we're really enriching for very, very sick patients, and importantly, patients who are unlikely to ever make it to CAR T-cell immunotherapy. And we saw this on the ZUMA-3 study. It was almost a 20-25% dropout rate from enrollment to infusion, almost entirely driven by refractory infection. And so one of the other interesting observations came from the MD Anderson group, where they looked at patients who were inotuzumab and blinatumomab failures, meaning they progressed after both agents, and now trying to take those, that group of patients into CAR T-cell immunotherapy, where they really observed it was very hard, even when CAR T-cell therapy worked, to really take advantage of that. And the survivals were quite poor in that series. So we want to be careful about sort of, integrating everything and then trying to use CAR as a last-ditch salvage, because odds are they won't even make it to the infusion, and when they do, they may get very sick afterwards, and it'll be even harder to keep those patients around. So where does that leave us then? What does it mean if we're not giving blinatumomab or inotuzumab before CAR T? Can we still utilize those agents after the CAR? Let's say they progress, or after the CAR doesn't work, and we want to try to salvage those patients. And this is where we had some very reassuring data, again, from both our pediatric colleagues as well as from the group at Sloan Kettering. In pediatrics, if we look at the combined experience of giving inotuzumab or blinatumomab or even a second CAR, the CR rate with that approach was around 59%. In the adult setting, and again, with the Memorial Sloan Kettering experience, that approach was associated with a 50% complete remission rate. In other words, this problem of having a patient who is progressed or non-responsive to CAR T does not imply that we can't successfully salvage those individuals with immunotherapy on the back end. That's I think a really important observation, and one that we need to build on. These are all small data sets, and I think that understanding how we manage post-CAR relapse will, especially as we start thinking about trying to integrate CAR T cell in earlier lines of therapy, will be critically important. One of the trials that we are hopefully going to embark on in the next couple of weeks or so will be a frontline CAR T cell study. This will be for patients with MRD after one cycle of induction. And so we really wanted to limit it to no more than one cycle of chemotherapy, and with any level of MRD, down to 1 in 1 million cells by next generation sequencing. Our hope is to integrate the CAR at that point, while we still have, I hope, preservation of the, both T cells and also with very likely some B cells there to drive CAR expansion, so that we can cure it and take advantage of keeping patients healthy, and at the same time feeling reassured that even should patients progress, we have chemotherapy, we have blinatumomab, we have inotuzumab, we have our rescue approaches in hand, all associated with high success rates, even in multiply relapsed patients post-CAR. And so that trial will open soon. There will be a similar frontline study coming from the MD Anderson group. This is going to take use their mini-CVD ino-blina approach, and so for patients, my understanding is independent of MRD, will receive this as a consolidation. And here we'll get to understand, again, these are not inotuzumab and blinatumomab failures. These are people who have responded to therapy. Can we consolidate with the CAR as a replacement for allogeneic stem cell transplant and improve outcomes in that context? And so it will be, again, really important to try to understand what we're going to see in terms of the CAR expansion. My understanding is they've already done this in the real-world setting for some patients, and we'll get to, I think, I hope, move into a world very quickly where we can take these novel immune therapies forward, sequence them in various ways, but ultimately use them to try to change the paradigm of 3 years of continuous therapy and really shorten that and prolong, hopefully cure a greater fraction of patients at the same time.